My device saved my life at least on 4 occasions. It's a brilliant technology. Still, just because it's a great technology and it saved my life, that I will forfeit my right to access the data that's generated inside my own body. That is not something I'm willing to give up on, and I never will.
Hello and welcome to Pulse Amplify, where we sit down with the leaders and changemakers shaping the future of health. Proudly brought to you by Pulse IT News. I'm your host, Louise Shaper.
And I'm your other host, George Margellis.
Today on Pulse, we are joined by Hugo Campos, a patient advocate who has spent the better part of 2 decades arguing with remarkable persistence that patients have a right not just to their own bodies, but to the data those bodies generate. After being diagnosed with hypertrophic cardiomyopathy and receiving an implantable cardiac defibrillator, Hugo discovered that vast amounts of information about his heart were being collected by his device, that's great, but it was being transmitted to hospitals and manufacturers, but was largely inaccessible to him. That experience ended up launching a global campaign for patient access to health data and ultimately earned him recognition as a White House champion of change for precision medicine. Today, Hugo is exploring something even more provocative. What happens when patients themselves start building AI tools to analyse their own health data, ask their own questions, and generate their own insights? He calls it patient-directed AI. And if he's right, the biggest AI disruption in healthcare may not come from hospitals, governments, or the tech companies. It's going to come from patients. Hugo, George and I are so excited to have you. Welcome to the Pulse Pod studio.
Thank you. I'm excited to be here.
Really looking forward to this discussion.
All right. So, Hugo, you are incredibly well known, but for some of our listeners who may not know your story, let's start back at 2007. So you're newly diagnosed, your doctors install an implantable defibrillator in your chest, and you ask a simple question about the data that it's collecting and how you can access it. Can you explain what shocked you most about discovering who had access to your data and who didn't?
Yeah. So it started off when the cardiac electrophysiologist who diagnosed me with life-threatening arrhythmias, he said to me, you're getting one of the first defibrillators that are capable of wireless telemetry. It was a new thing. It was, I think, a model that had just come out in 2006. And he was very excited about that because the idea was that the patient would have a box next to their bed and the ICD would then transmit via a little radio transceiver, would transmit the data to the box, and from the box it would go by phone line to the manufacturer of the device, and they would then generate the reports or alerts and then send it to the clinic for patient management. And I was excited too when he explained to me. I was like, wow, this is great. So what is the URL for the patient portal? And he looked at me puzzled and he said, oh no, it's not for you, it's for us. And I was like, how does this make sense? I'm the patient. I'm the person who has the most skin in the game. And aren't you busy with hundreds of patients? Don't you have a busy practice? Are you going to be monitoring me? Let me do that part. And it wasn't really something that the system was prepared or willing to deliver or share. And that was really frustrating. And that's what set me out in this path of trying to liberate the data. And I felt it was really a profound ethical wrong because, after all, I'm the person living with the device. And don't we have agency over our own bodies? And so it was very upsetting to me. And I thought it was wrong and it had to be fixed.
And what point was it in your journey when you realised that it's not just a paperwork problem, but a fight really about who healthcare is actually designed to serve?
It became clear on the first 3 years of my cardiac care. It took me 3 years to get properly diagnosed. When I received a defibrillator, was the end of those 3 years of seeking a proper diagnosis for why I kept passing out and having these terrible arrhythmias and really getting close to having a sudden cardiac arrest. So it took about 3 years to become a little more aware of the fact that I had to engage and have a voice in what I believed and felt was important and what mattered to me and was aligned with my values and my preferences as a patient, because no one else would.
That diagnostic journey with hypertrophic cardiomyopathy is well known. It is a complex disease to diagnose. Did you find that the clinicians along the way kept you in touch with what was happening, or was it really much, we're doing the test, we'll look at the results, we'll tell you what's happening, rather than working with you as a colleague or as a partner? Was it the fact that they just never really conceived the idea that a patient would want access to this information?
Yeah, no, I think it's a little bit of both. So a lot of the first answers that I would get were along the lines of, why do you want to know and why do you care? And why is this important? You're in good hands. We are the professionals. A lot of folks took it defensively, as if I was questioning their competence or their capability. And to some extent, I actually was, because I had reasons to. But it wasn't mostly that. It was a mix of curiosity. It was a desire to engage. And frankly, in retrospect, it was also a way to cope with a very significant, life-changing event. I was 37 years old when this happened, and I felt I was on top of my life and as good as it was ever going to get. And it was shocking to be told that I was at risk for a sudden cardiac arrest, and that all of the events that I had been having over the past years were, in fact, significant enough that could have deteriorated into a cardiac arrest. Coping was part of that too. So it wasn't just wanting to have access. They weren't even considering the possibility that a patient would want access. There were no mechanisms to deliver these reports to patients. And it was very frustrating, because imagine this. Imagine your house keys are kept with your neighbor, and every time you come home, you have to bother them for the keys so they can let you in. And they ask you every time, where were you and what did you do? It felt like a loss of autonomy and a loss of agency, self-determination. And it's like, I'm a grown person. I'm accountable for every aspect of my life. How come healthcare is any different? How come am I treated as a baby when it comes to caring for my health?
When did you realize that you would become a patient advocate for data access rights? Because you were just living your life and doing the best you can for yourself.
Yeah, and it's funny. No, it was not something I aspired to be, or I was just trying to fix something that I felt was wrong. And I tried going different places and speaking to different stakeholders and different communities and different groups of patients and government and people in policy, academia. I would speak to anybody who would listen. It wasn't an advocacy that was in any way strategically planned or anything like that. No, not at all. It did change my life. When I was diagnosed, at that time I was working at an ad agency, and I was perfectly happy being a creative director at a small ad agency in San Francisco, Chinatown. It was a wonderful job, and I worked with great creative people. It was really fun. But suddenly everything was put into perspective for me. And I felt like I had more important things that I had to do. And quite frankly, I kind of had to go through a period of adaptation as I got used to living with an implantable defibrillator and the mindset that comes along with it. I never thought I would just be an advocate. And frankly, a lot of times when folks have praise for some of the things that I do, I always feel like it's not properly put. I know there are so many other people who deserve praise. I've just been a loudmouth and talking about the problem.
So around about the same time in 2007, I was working as a medical lead at Intel. We had this thing called the Continue Alliance. Medtronics and other companies were involved in trying to learn how to share data, but to be honest, the focus then was to try to share data within our own ecosystem. And we had people like Eric Dishman who raised the issue around, okay, well, what about patients? But often it was just that blindness to the fact that the patient would want to see this data. But what happened? Did you get your data in the end?
The CEO of Medtronic at that time was a man by the name Omar Ishrak. And he responded to one of my tweets, which was quite significant to me. And he got one of his top folks at Medtronic to really listen. And they really gave me a good amount of attention. And I believe they were, for the most part, quite interested in trying to figure out a way. The challenge is that this does not align with their business goals and their business model. And even if they want to help, it's just not something that they can justify from a business point of view. And these are for-profit.
What, do you mean like the expense? Because there's no harm to the business. It's just a cost if they were to open up that data and provide access. Is that what you mean?
That's what I mean in part. There's more to it that is not quite evident at first. One aspect of it is how their brand and how their business is perceived by physicians. Physicians are the customer. The patient is not the customer. The patient is the data source. The clinician is the prescriber. The clinician can decide whether to implant a Medtronic device or a Boston Scientific device or an Abbott or a Biotronic. And the clinicians are quite conservative when it comes to this point. So it may be considered too risky for a company that makes these devices to open it up to patients because they see it as interfering in the doctor-patient relationship. And it's not their business to interfere in that. And their business is to design and build these safe and effective devices and make them available to clinicians. And these are incredible machines, and they're life-saving. My device saved my life at least on 4 occasions. It's a brilliant technology. Still, just because it's a great technology and it saved my life, that I will forfeit my right to access the data that's generated inside my own body. That is not something I'm willing to give up on, and I never will.
And you did get access in the end?
Not quite. So it was an ad hoc solution. They were trying, but not really a solution that would solve it for everybody. So the problem remained. And I didn't really want to solve my problem only. I wanted to fix it for everybody. I wanted to fix it. It's just wrong. And it's not right. It's just got to be fixed. So the problem persists to this day. Crazy, right?
So I do have to tell you, you did have an effect because I ended up working for Omar Ishrak further down the track when he became the chair of Care Innovations. And he did become an advocate for consumer engagement. So you must have had a very early effect on him because one of his mantras was, we need to engage with consumers more. Yeah. Kudos for that.
Thank you. Yeah, I think every one of us who has shared a story or expressed a need to access data and information about our body has contributed to a global narrative. And nowadays, it's much more acceptable and to some extent even expected that people will have access to their health information. So in the work that you guys have done as well, by sharing stories and by contributing to the conversation, all of us managed to raise awareness, something that is just very old school, right? It's just what's with this gatekeeping attitude from the last century. It really is very last century. So 20th century.
Yeah, very much. Yes. Medicine's not going to walk away from paternalism anytime soon, but it is getting better. So that's good. Now, let's look at the current day. So AI, is it changing everything? 15 years ago, you gave a TED talk. You're the guy on stage waving an X-ray of his own chest. But recently, you sat down with Claude Code, and about 3 hours on a Sunday, you built a longitudinal dashboard that the manufacturers never ended up giving you. So what did it feel like to finally have that? But also, I was thinking it must be a point of elation, but at the same time, frustration that you had to do it yourself after all these years rather than the industry just doing the right thing.
Yeah, this is so interesting. Thanks for this question, because there's no frustration really. It was mostly elation.
Okay.
And
Cool.
and I tell you why. It's because it's empowerment. Today, everyone can do this. And I hadn't realized this until I started using Claude Code. And I felt intimidated because I'm not a coder. And I thought, I'm going to not know what I'm doing there. But I gave it a shot. And soon enough, I was directing Claude Code to build apps.
Yeah.
But I usually tell folks two things that I think are important, and I should probably say them here. One is don't use AI as an oracle. It's not an answer machine. It really is a thinking partner, a coworker or a collaborator. And I should say is best used when used as a thinking partner, when you retain your critical thinking and when you retain your agency, and do not delegate either. But really use AI to explore possibilities and open up different avenues of thought, of possibility, of decisions and opportunities. So that's really important. Never use AI as an oracle. Use it as a thinking partner. The other thing that I think is important as we graduate into using these more capable tools like Claude Code and OpenAI Codex, both of which I use, I think three things are important, foundational domains. One is understanding a context, and that's where data lives. So it's really understanding how to use data, where to get it, how much is too much data, how much is not enough data. We all have to be a little bit of health informatician nowadays, citizen informatician, if you will. So the more you know about data, the better off you will be at fending for yourself with a tool like AI in your hands. The other domain is tools. I'm AI agnostic, and these tools are very different, and they work very differently. There is an entire portfolio of large language models that are different, and they are applicable to different uses. And so it's important to be familiarized with the tool. And the third and probably most critical domain is agency and critical thinking. And it really is keeping our ability to make decisions and not delegate too much to the AI. So yeah, those are the three domains that I think are important.
Excellent. And obviously there's a continuum of patients who want to dig in deep and those who don't. But you also talk about the difference between institutional AI and patient-directed AI. Can you unpack that for us?
Yeah, I think by institution, what we mean are healthcare institutions, the traditional health systems or the payers, the regulators or academia. And so what I mean by this distinction between institutional AI versus patient-directed AI, at the heart of it, it really is about who deploys these tools and for what purpose. What I have noticed in the last 3 years, it's been mostly about what AI can do for hospitals, for health systems, and for doctors. So it really is about meeting the goals and the objectives of the institution. And I find that a lot of times the AI in this context can function as a way to constrain the freedom and the ability of doctors to help patients. And quite frankly, a lot of times the patient goals and values aren't always aligned with the goals and values that matter to the institution. It's a margin over mission, right? So if we can't stay financially healthy, we can't do our mission. So patient-directed AI is patient use of AI in a way that aligns with our goals and our objectives. It really is an AI that serves me, and it's not there to serve the institution.
Well, it is time for a quick break, and we will be back very shortly with more from Hugo Campos. Well, let's have a chat about the concept of patients building their own N of one applications. So can you paint a picture for us? What becomes possible when patients can start creating personalised tools for themselves?
Yeah, so this is, I think, what's one of the most exciting things happening right now as we go into the age of agentic AI. And it really is us, like regular people, who are deploying AI that works for us on our goals and on the things that matter to us. So everything that I think of in terms of ideas and problems that I would like to solve in healthcare, I feel like I no longer have to engage with somebody at some high, powerful position and pitch the idea and convince them to deploy it or pursue it. I really don't have to. I can now just do it myself a lot of times. To give you an example is my healthcare system. They have a portal. In fact, they just deployed a new version of the portal. But it's never really, it doesn't always work for me. I find it terrible. It's not friendly. It's cumbersome. It's horribly designed. And this is the best they can do. They just released it. And so it's like, why keep waiting for them to develop something that works for me, which will never happen? And so I built an MCP server. It's basically a program that runs on my computer that uses my credentials to access the endpoints of the server that feeds the data into the portal. So I bypass the portal entirely and go straight into the endpoints to pull the data out. And if I'm not explaining it well, I guess that's part of the point, is because I don't understand exactly how it works. But I can tell you that I built the whole thing with Claude Code and OpenAI Codex. And by the way, it is free and available for anyone to use on GitHub. It's called openkp.org. So it's mostly for accessing data at Kaiser Permanente, Northern California. And I don't know how many hundreds of thousands or maybe a million people in Northern California who are KP members, they can use that. At the same time, Ryan Hughes, he's building his own thing, does the same thing. He pulls the data from an Epic portal. I figured I'm not a coder, and I was sitting here and looking at this, and I kept just hoping, I wish I knew how to code. And so I typed on Claude, I said, take a look at this Ryan Hughes GitHub repository and see if any parts of the code can be used for me to access my Kaiser Permanente data. And Claude says, no, I wouldn't do that. It's not built for that, so you're going to have to take it apart. It's going to be a lot more laborious to take it apart and rebuild it from the ground up. What we can do, this is like a conversation I'm having with the AI, right? It says to me, what I can do is we can build it from scratch right now. We can spend half an hour. I was like, seriously? A half an hour?
Yeah.
A half an hour and we can build it? And Claude was like, yeah, we can just see if we can interrogate your patient data. Just see if we can read the record and we can go from there. If it works, we can keep on building. And I was like, all right, I don't believe this is going to work, but okay, let's do it. And so Claude starts coding and it tells me what to do. It says, open up a browser, open up the developer tools, capture this, capture that, save a HAR file, which I had never heard of, what it was, HAR file, and save this, put it here and type this in the terminal, type that. And I'm like, okay, I have no idea what I'm doing.
I love how it's navigating and mentoring and coaching
It's
you
nuts.
as well. It's really something as a partner that you're doing it together.
That's what I'm saying. This is what's changing. And so,
cool.
And it's really, it was encouraging me to do it as well. And it said, okay, it's great. It's working. Let's try this. Let's run the MCP server. And it started working. In a matter of 30 minutes to an hour, it was already working. And I was like, wow, this is incredible. So I said, I want this to be an open source product. I want to share it publicly. I don't want to have any of my PHI in there. So we worked through a design document. Claude created a project folder for this, and you're going to need a Git repo. And I was, okay, let's put it on GitHub. I don't know the first thing about GitHub. Give me your credentials and I'll plug it into GitHub and I'll do all the connection to GitHub myself. Claude says that to me, right? Where do you want to host it? And I'm like, I have no idea. And it's like, oh, how about these places? And it gave me a few options of where to host it. And I was like, I don't have any money. I want a free hosting site. It's like, oh, this would be great for you here. Then use this. And 2 weeks later, I have a functioning tool. I think it has 22 or 25 different tools at the moment. And it does things that the KP portal cannot even dream of doing because I can ask questions of the data. And in fact, I use it all the time. And now I use it through different agentic tools. And I like to ask questions of the data with a very specific lens that I like to call critical AI health literacy, which is really interrogating the world, not interrogating the output, and interrogating more than simply asking questions about a condition, but really asking questions about the entire system in terms of power dynamics, of access, in terms of seeing access really through my lens, not the lens of a doctor.
Yeah, the information that's important to you.
Exactly. So what matters to me? I built a skill based on a paper that I wrote with Liz Salmi that was published on the National Academy of Medicine Perspectives last year on critical AI health literacy, critical AI, CAIHL.org. And that is a skill that anybody can download and put it into Claude, and it helps you see your care through those lens of critical AI health literacy. Today, I had an appointment for my dad it was the first appointment, endocrinology. And I had the app running on my phone, and I was able to ask questions during the visit, questions that I did not know the answer to about labs and questions about procedures and a bunch of other questions that I would never have been able to ask if I didn't have this in my pocket. And what the phone does is access through Claude Dispatch or through the remote feature of OpenAI Codex. It connects to my desktop and can access data. So again, context, tools, and agency. So really empowering mix that I think for the first time in history is available to anybody, whether you're a coder or not.
So if every patient actually has their own AI agent managing their history, their medications, their data, their medical records, does that lead us to a more personalized system? Or does it open up a new challenge where the information now is much more fragmented and everyone has their own subsets of data outside the general domain? Can that cause challenges to a system which is already challenged in delivering care?
I think both things are true. I am overwhelmed with data and technology. Frankly, I should say I'm frequently feeling overwhelmed by data and by information. Overall, I think because we now have the ability to curate information in a much more efficient way, and because we are able to deploy these agents on different parts of our lives, we at least have the potential to do a better job and be more efficient at managing some of these more complex problems, because it can help surface problems and give you a little bit more clarity. The trade-off is being inundated. And because we have more data and more information, it's not necessarily helpful because a lot of it can be noise and not useful. And so I am finding that what is a challenge for me is to really be more efficient at how I curate the data that I have access to. How do I store it? How do I organize it?
I guess the key thing is that we're all still on a learning curve. The reality is this is still very new technology, so we're evolving. So obviously having the communities of interest online and being able to share is a huge part of that.
Yeah, but I think it's real. Your concern and what you bring up is a real issue. It's really, again, back to those three domains that I talked about. It kind of falls in the first domain of context and data, and how do we really make sure that we are organizing information and saving what is useful and not. I tend to be a hoarder of data and information, and if I come across something, I save it because I think I'm going to need it later, but that's not necessarily useful. I think it's better to be smarter about what you save and what you keep.
So, Hugo, I want to end with a couple of pieces of advice that you can give to our listeners. One of the reasons that George and I have made patient use of AI a major theme across this show is that it frankly concerns us that healthcare is underestimating this technology and the power of it for good as well as for, let's say, not so good, because it's something that the healthcare establishment can't control. We have significant numbers of people who listen to this show, and many of them have very big, important, influential jobs. So what's your advice to those who see themselves as part of the traditional healthcare system, whether that's health ministers, policy people, clinicians, hospitals, tech companies? How should they be preparing for this genuinely new territory where AI can give ordinary people like you and me access to knowledge and capabilities that they never previously had? What should the healthcare system be doing to prepare?
Yeah, I would encourage them to explore, see what the possibilities are, and really embrace this. It's a paradigm shift. I recognize that it can be scary, and we're in the middle of significant change, but there's no not going through it. We will go through it, and things will change. We have to shift our thinking from being the gatekeeper to enabling better use of these tools in a responsible way. I think we'll all be better off with access. Folks will continue using AI, and we have to waken in people a sense of responsibility and the realization that we are responsible for ourselves. And like any decision that we make, it comes with consequences. These are very powerful tools, but very useful tools and very helpful tools. It's like we're shifting from riding the horse to riding in automobiles, and we all need to learn how to drive, and so we can get to places faster.
Absolutely.
So Hugo, you spent years arguing that patients should have more access, more information, and more control. As AI becomes increasingly powerful, what's the one thing patients need to do now to ensure they remain active participants in their care rather than becoming passive consumers of AI-generated advice?
Yeah, it depends on attitude. Not everyone will be an active driver of AI. Some people will be passive recipients of AI outputs. It's a choice that each one of us has to make. And I'm not here to tell anybody how they should live their lives. I want to be able to have a voice and agency and shape the life that I lead. But people are different. And I understand that it's not appealing to everybody, and that it's also not possible for everybody. One of the concerns I have is that these tools are expensive. And
there's an equity issue.
There's a serious equity issue, yes. I'm no longer in the $20 a month plan. I'm in the Pro plan for OpenAI, and I'm on the Max plan for Claude. And so the concern I have is that we'll exacerbate inequities, and the line would be drawn between the folks who can afford to use powerful AI tools and those who cannot. So I hope that we can figure out ways in which communities can share, maybe disease communities can run their own AI models, figuring out how we can put these tools to work on our behalf. And maybe that can be a safer space for those folks who do not wish to engage actively.
There's an interesting concurrent debate within the medical community now about not using AI. Is that tantamount to malpractice by the fact that we're not using the tools that we have available? Are clinicians actually not practicing best practice medicine? So the debate's happening on both sides of the domain. What we need to do, obviously, is try and get both sides to collaborate together and use AI together as a tool for improvement. And that's obviously requires some significant reform of our healthcare system, which I'm sure we could discuss for many more hours. But thank you very much. I think we've had a fantastic discussion today.
Hugo, thank you so much for coming onto the show. It's been wonderful. We have so much amazing advice and content here. We will be putting a lot of links in the show notes. So for all the listeners, there is numerous URLs that Hugo has shared, which I would encourage you to check out, including a community for AI patients as well. So Hugo, thank you so much for your generosity and for doing so much valuable work for the community.
Thank you so much. It's been a pleasure. And I love Australia.
Have you been down under?
It's Sydney only.
Hopefully we'll get you down here again soon in the future.
Okay.
Yeah, definitely. Bye. Thank you for listening to Pulse, brought to you by Pulse IT News. Pulse is produced by me, Louise Schaefer, and Ivan Jurek of Octopod Productions. Thanks to Emily Mara for all of her support. Big thanks to all of you for listening, and please make sure you subscribe, follow, and rate us wherever you get your podcasts. Visit pulseot.news to catch up on all the news from Australia, New Zealand, and Ireland. And of course, send any feedback or topic suggestions to us on email, pulsepod@pulseit.news. George and I always love to hear from you guys. Bye.